Hello, thank you for joining me for this UCLAMDChat webinar. My name is Eugene DiPasquale. I'm an advanced heart failure cardiologist as part of the UCLA Heart Transplant, Heart Failure, and Mechanical Circulatory Support program. And I'm here to talk to you today about the new UNOS status system and how it will affect patients listed for heart transplantation. So I'm going to touch on several key things. First off, when will this go into effect? Why this change is happening, as well as what are the potential implications for this change. So to start off with when this is happening, so as far as September 18th, transplant centers will be able to start updating the patients who are currently listed for their new statuses in the new system. And then this will go into effect for organ matching for patients listed for transplant on October 18th. So only a few short months away. Now, why is this change happening? The UNOS committees looked at the survival of patients who are waitlisted for transplant. And as you can see, the mortality with the current system is quite high. And the new system is aimed at trying to reduce that as much as possible. And so these two bars to the right of the screen reflect the proposed system with just the status changes. And then on the farthest right is how this will impact and decrease the chances of dying on the wait list when incorporating a geographic change to this process as well. And I'm going to get into the nitty-gritty of that in a little bit. But this also reflects the new statuses and how the mortality will be affected by each of these statuses in the new system. And a large question is, how will this change rates of transplant? Well, in the modeling that's been done thus far, and one limitation is this is with current data, not using the new system because it hasn't gone into effect, that the wait list or the transplant rates should remain relatively stable. So it shouldn't be affected too much is what's currently predicted. Now, before I get into the UNOS statuses in and of themselves and the details of that, I wanted to talk first about the geographic change that will be happening. So in the current system, what happens is if a patient's listed for transplant, it's by priority. So the highest priority is 1A, followed by 1B, and status 2 would be the lowest priority. And so for the current system, if a heart becomes available in our local region, then that would get offered to the centers in that region first for their 1A patients, followed by 1B patients, before moving to all centers within 500 miles for their status 1A and 1B patients. And then this will come back to us for status 2 patients and so on. So what the new system aims to do is to increase the reach of organs for patients who are at the highest risk of death on the wait list. And the committee defined this for status 1 and status 2 patients. So for these patients, status 1s and status 2s, organs will become available for those patients for all the centers within 500 miles right off the bat. And then after it goes to status 1 and status 2 patients, then it will come back to the local region for their status 3 patients. And then it will go to all the centers within 1,000 miles for their status 1s and status 2s before going back to the local status 4s and so on. So this really aims to increase the access of organs to patients of the highest risk of dying without a transplant. And so to put a picture to what I've just described, this is what the map currently looks like. And for our center here in Los Angeles, we're down here in green, so our 500-mile radius incorporates centers in Arizona, Northern California, and a little bit of Utah. And then you can see other centers further out. So you can see how this may affect organ allocation, but it's important to potentially increase the access of organs for these patients who are really at high risk of dying without a heart transplant. So I'm going to shift gears to the statuses themselves. So I already talked about status 1A, 1B, and 2, which is the current system. And so what the Thoracic Committee really did in essence is divide status 1A into 3 statuses. And how they chose what went into these statuses is they looked at the existing data and looked at the risk of dying without a transplant for each of those categories. So there's status 1, 2, and 3, and then status 4, which is the equivalent of the current 1B status in essence, and status 6, which is the equivalent of status 2. So I'm going to touch on some points before moving on to the nitty-gritty of these statuses. And the one thing I want to highlight you to is the red asterisks. And so those highlight statuses that are not only time limited, but have hemodynamic requirements. And so one aspect of the new system is to incorporate those details to really try and objectively assess a patient's risk and imminent need for transplant. The other thing I want to highlight is status 4. So status 4 is really the first time the statuses for listing have incorporated a patient's diagnosis into this. And I think this is something that will potentially evolve in the next generation of these statuses, which I don't know when that will be, but I think that it incorporates patient's physiology into that the prior statuses could not well incorporate. So I'm going to touch on these all as we go through this presentation. And so just to re-emphasize this hemodynamic requirements, so the UNOS Thoracic Committee really defined what cardiogenic shock is. And for the basis of this, they used the American Heart Association consensus statement to derive these definitions. And so for the purposes of at least status 1 and status 2, cardiogenic shock is consisting of one of the following within a 24-hour period of time. So a very low blood pressure, so a systolic blood pressure less than 90, cardiac index, so essentially a marker of the blood flow throughout the body, but a cardiac index less than 1.8 without assistance of inotropes, or less than 2 with inotropic support. And then a wedge pressure, so a marker of how much extra fluid on board, in essence, greater than 15. Now, if those are unable to be obtained for whatever reason, the other thing that may qualify you based on the hemodynamic criteria is one of the following within a 24-hour period of time. So if the patient underwent CPR, if they had a blood pressure less than 70 for systolic pressure, a lactate, so a marker of poor perfusion greater than 4, or elevated liver enzymes greater than 1,000, so another marker of poor perfusion and other organ dysfunction. And so if you meet those qualifications, you can be in the equivalent status. Now, this is not indefinite, and these statuses are time limited. And so for patients who are listed with balloon pumps, for example, or Impella percutaneous support devices, you are granted 14 days in this status, or 7 days for ECMO. After this period of time, there is the opportunity to continue on and have an extension of that status, but 2 things need to be met. The first is that the hemodynamic criteria still need to be met, so the hemodynamic criteria still need to be met, and also that an attempt at weaning has failed. And so how this is defined is a MAP, or mean arterial pressure less than 60, a cardiac index less than 2, a wedge pressure greater than 15, or an SVO2 less than 50%. Now, if one of those are met, the other criterion that needs to be met is that there is a documented contraindication to proceeding with a durable form of support, such as a ventricular assist device. And so this would be adjudicated by a review board that will be outside the region. And so this has not gone into effect, so it's difficult to predict what the review boards will be looking at to define that. But in essence, if the extension is not approved by the review board or the center chooses not to extend this status, then the patient will be downgraded to status 3. Now, what are the things that qualify you for status 1? These are things that are markers of poor cardiac perfusion and cardiogenic shock. So the requirement of ECMO support, needing a biventricular assist device that is not able to be discharged, that is surgically placed, having a ventricular assist devices with ventricular arrhythmias, with the caveat in that category that attempts have been made to treat this, that an electrophysiologist deems that the patient is not a candidate for any other alternative therapies, and that this all occurs in the setting of normal electrolytes and optimal antiarrhythmic therapy. Additionally, status 2 has slightly similar requirements, but to qualify for status 2, these are patients who have total artificial hearts. They have dischargeable biventricular assist devices. They can also have a right ventricular assist device alone, or congenital patients with single ventricle physiology with a ventricular assist device can be status 2 in this category. Other things that can place you in this category are if you have a ventricular assist device and the ventricular assist device has a malfunction. And then you have to meet these additional criteria, but in essence, you would fall into this category as status 2. Additionally, patients without ventricular assist devices who have refractory ventricular arrhythmias can be listed status 2. You need to meet the same requirements as the former category in that you have to have refractory ventricular arrhythmias that are not in the setting of abnormal electrolytes and that have been optimally treated with antiarrhythmics, as well as documentation by an electrophysiologist that this patient is not a candidate for other therapies to treat this rhythm. Now, shifting on to status 3. Now, this is by and large the most common status that patients get transplanted at if they don't have a ventricular assist device. And for this status, particularly with inotropic support, what requirements include having a Swan-Ganz catheter, so a pulmonary arterial catheter, daily measurements of cardiac output and filling pressures, and also the demonstration that there have parameters of cardiogenic shock, so similar to what we talked about earlier. So again, to reinforce, that's a systolic blood pressure less than 90, a wedge pressure greater than 15, and then a cardiac index less than 1.8 without inotropic or mechanical support, or less than 2.2 with those support therapies. Now, additionally, these patients need to be in inotropic support. And the UNOS Thoracic Committee has deemed these agents as what would qualify for qualification for this level of support. And they also define minimum dose requirements. And I'm not going to go into each of the specific doses because you can see that here for you. But this just is a reflection that these patients need high level of support and warrant transplantation. Now, like the other statuses that rely on cardiogenic shock parameters, there will, after a 14-day period of time, this status will need to be extended. And to meet that extension, the hemodynamic requirements need to be met again. And so that could be a failed attempt at weaning, or that they still have a cardiac index less than 2.2 with their current level of support. Now, what UNOS defines as a failed wean is that when you start to down titrate these inotropic therapies, that their cardiac index falls to less than 2.2. Additionally, if the creatinine rises by more than 20% from their prior value within a 24-hour period, this would qualify, and that's in the setting of weaning the inotropic support. Additionally, if the lactate rises to greater than 2.5, which is another marker of poor perfusion, as well as an SVO2 less than 50%. These are, each one of those things would qualify as a failed weaning attempt. Now, there are other things that qualify you for this level status, and all LVAD patients get 30 discretionary days at this status, so that can be used at any point in time after their VAD placement. After those 30 days, they are exhausted, or if they're not being used, they can be listed at status 4, which we'll get into in a little bit. The other thing that qualifies you for this status are certain VAD complications, or mechanical circulatory support complications. And one of these includes having device hemolysis. And for this, certain characteristics need to be met. So you need both of the following. So you need, apologize for that. So that would require 2 samples with markers of active hemolysis. So that would be an elevated LDH as described, an elevated plasma-free hemoglobin as described, or having hemoglobin documented in the urine. Additionally, there has to be a documentation of an attempt to treat this with the agents that are described here for you. If you meet those criteria, then you can be listed at status 3 with a device complication. Other device complications that qualify for status 3, including having pump thrombosis, and I'm not going to go into the nitty-gritty of what's described for you there, but also if you have right heart failure with mechanical circulatory, with MCS support. And to qualify for that, you have to have at least moderate RV dysfunction without LVAD malfunction, and one of or both of the following. So you need to have documented treatment for that RV failure with one of the agents for a 14-day period described here. And there are minimum dose requirements. And you also have to have the demonstration that the wedge pressure is less than 20 and the right atrial pressure is greater than 18 to meet the criteria to be in this status. Now, certain types of device infections with MCS can be listed for status 3. I'm not going to go into the nitty-gritty of everything that qualifies you for this status, but depending on the extent of the infection and how it's been treated or the requirements for treatment, you can get anywhere from 14 days in this status without needing to extend it, or up to 90 days. Additionally, if you're having mucosal bleeding in the setting of MCS therapy, you may qualify for status 3. Again, there are requirements, and those requirements include having documentation of transfusions, that this occurred in the setting of an INR less than 3, as well as having a hematocrit drop. And then depending on the amount of transfusions and hospitalizations, etc., you can have 14 days or up to 90 days before the status needs to be extended. And finally, if you have an MCS device and you have documentation of aortic insufficiency or regurgitation, you may qualify for this status. The components that are required to stay in this status are having at least moderate aortic regurgitation in the setting of a mean arterial pressure less than or equal to 80, a wedge pressure greater than 20, or New York Heart Class 3 to 4 symptoms. And you may stay in this status for up to 40 days before extension. Now, the final things that may qualify for this status are ECMO support, intra-aortic balloon pump, percutaneous endovascular MCS such as Impellas, as well as non-dischargeable surgically implanted endovascular LVADs. Now you see that these are all time limited after 7 days, 14 days, and 14 days, and that's largely because the first time around these patients may qualify for status 1 or status 2, depending on their level of support. And after you downgrade from that status, you meet qualifications to be in status 3. Now, shifting gears to UNOS status 4. And this by and large is similar to the status 1B from the former and current version of the statuses. But as I mentioned previously, this starts to incorporate aspects to the patient other than what support they're on or their degree of support. And the unique things in this status are the incorporation of certain types of congenital heart disease to meet the qualification to be in this status, as well as hypertrophic or restrictive cardiomyopathies, amyloid. Patients who need retransplantation can be in this status. And what existed before is patients with inotropes without hemodynamic monitoring. And as mentioned before, if the discretionary days, status 3 days, are not being used for an LVAD, the patient without a complication can be listed in status 4 without justification. Now, as far as the patients with inotropes without hemodynamic monitoring, again, what's new and what did not need to be documented previously is that they also need to meet hemodynamic criteria, so wedge greater than 15, a cardiac index less than 2.2, and one of these inotropes, at least one of these inotropes at these dose requirements. And shifting gear, so before I move on from this, and you can be in the status, I believe, for up to 90 days, and then these requirements need to be met yet again. Additionally, patients with ischemic heart disease with intractable angina can be listed at status 4. Now, there's certain requirements to be in this. Obviously, having coronary artery disease is one criterion, but you have to be the Canadian Cardiovascular Society grade 4 angina that cannot be treated by standard therapies, which include medical therapy, percutaneous therapies, or surgical therapies. And you also have to have the demonstration that there is ischemia by an imaging modality. Now, amyloid cardiomyopathies, hypertrophic cardiomyopathies, and restrictive cardiomyopathies can be listed as status 4. And this is something, as I mentioned before, that is new to the statuses. And certain requirements need to be met to qualify for status 4. And one of the following needs to be demonstrated. So again, that angina scale grade 4 that cannot be controlled with medical therapy, having class 3 to 4 symptoms, and with a demonstration of a cardiac index less than 2.2, or having the demonstration of elevated filling pressures in some way, be it the right or left atrial pressures, the left or right ventricular end-diastolic pressures or wedge pressures greater than 20. Or you can have ventricular arrhythmias or prior sudden cardiac death. And finally, status 4 can also, retransplant candidates can also be listed status 4. And obviously you have to have had a prior transplant to qualify for this criterion. But you also have to have the demonstration of transplant coronary artery disease or transplant vasculopathy that's at least ISHLT grade 2 or more. Or the documentation of class 3 to 4 heart failure symptoms. Now, for some of the statuses, for some of these status 4 patients, there's additional guidance, which I'm not going to go into extensive detail on, but there exists documents that provide further clarification for patients with hypertrophic and restrictive cardiomyopathies, as well as those with congenital heart disease on what may qualify to upgrade them to statuses 1 to 3. As these patients may not easily fall into those statuses for whatever reason, be it having multiple prior surgeries or complex anatomy, or the therapies really exacerbate their underlying heart condition. So I'm not going to go into detail of these, but these documents do exist for those patient populations that may still be at a disadvantage with how the statuses are currently delineated. Now, what are the implications for this? So I'm going to show you the UNOS data that was used to model this data. And so this reflects the system as it currently exists, looking at patients currently patients who were waitlisted for heart transplantation between 2009 and 2011. So you can see that there were 2,200 patients who were 1A, almost a little over 3,000 who were 1B, and 3,300 who were status 2. And I didn't adequately explain status 7, but status 7 means you're on hold for transplant for whatever reason, be it a contraindication to currently proceeding with transplant, or that patient has improved functionally and may not need transplant, or a whole slew of other reasons. Now, what will this look like in the new system? So with the new system, statuses 1, 2, and 3 are essentially status 1A broken apart. So looking at status 1 and status 2, that represents almost 500 patients. And so the patients who are currently listed 1A, who would qualify to be status 1 and status 2, theoretically should represent a very small proportion of the whole patient population who are undergoing transplant. So augmented priority in terms of organ allocation should not make a dramatic difference if centers are listing with the new system as they are with the current system. Now, status 3, much like the 1A, represents the largest proportion of patients, and that's almost a little over 1,600 patients. And status 1B, or status 4, represents 1,500 patients. And there's a much smaller percentage of patients who are statuses 5 and 6. Now, I didn't discuss status 5, but I'll mention it briefly. And those are patients who are listed for multi-organ transplantation who don't meet the criteria to be in statuses 1 through 4. So they have higher priority than status 2, but they don't qualify otherwise to be in a higher status. Now, what are we going to do with these new statuses? So part of the goal of the Thoracic Committee who developed these statuses, it was not only to better prioritize patients who are at greatest need for heart transplantation due to highest risk of mortality, but also to collect data to be able to improve the system. And what may ultimately be needed is a heart allocation score. I highlight this paper, but there are other papers that have since come out. But in essence, this looked to model current UNOS data and derive a score to see if we could predict how someone would do with transplant and try and derive what the need for transplant would be and how they would do with transplant. So similar to the concept of the lung allocation score that currently exists for that. But the Thoracic Committee currently felt that the existing data was not enough to warrant the development of a heart allocation score, and that largely stemmed for incomplete data, the increased use of mechanical circulatory support, and other things that were not well captured, such as the antibody status or sensitization status of patients. But hopefully with the new system and the increased data collection, this can be used and derived in the future. And so to kind of give you a re-overview of the statuses and the geographic changes that are forthcoming in October. So just to, on the right kind of is a map of the zones. So just to emphasize that this will change dramatically depending on your level of priority for transplant. And this will change for statuses 1 and 2, where instead of hearts being allocated first to the immediate local region, hearts will become available for those two statuses right off the bat to all centers within 500 miles before coming back to the local region for status 3 and so on. Finally, to talk about the statuses. So the statuses incorporate or divide status 1A into 3 different statuses, and these statuses were derived based on the waitlist mortality with each of these categories. And not only did the Thoracic Committee delineate these categories based on the waitlist mortality, but they also started to incorporate hemodynamic criteria, which I think will be critically important going forward to really help prioritize these patients better in the future. And so I'm not going to go into the nitty-gritty because you can see it on the screen for you of the details of these statuses, but then there's one step forward, I believe, with status 4, incorporating patient diagnosis into the mix, which can be a bit more nuanced and not be completely or neatly fall into one of these statuses, or at least how the statuses were previously. So to summarize, the impending changes are intended to increase geographic allocation as well as to better prioritize for those patients who are more in imminent need of heart transplantation. Now, there will obviously be intended and unintended consequences of these changes and will need to be monitored closely going forward, but ultimately a heart allocation score is needed to move forward and really be able to define a patient's risk better, but the new system will hopefully aim to better allocate organs to those in the greatest need of these transplants. So I want to thank you for your attention, and I understand that there are some questions. I'd be happy to answer those. So one of the questions I see here is, if I'm already waiting for a heart transplant, what does this mean for me? So if you're currently listed for a heart transplant, you will be converted to the new system, and that the conversion will be based on an algorithm that UNOS has derived to convert the time that you've currently been waiting to the new system. So you won't lose any time that you've currently had. And as far as how long will it take to get transplanted, I think that is unclear until the new system goes into effect. But looking at how the statuses are delineated based on how centers are currently listing their patients, I think that the prioritization is probably good, and as long as you're in the correct status, you should be transplanted in appropriate time fashion. And then the last question I have is, if I have heart failure and I'm in need of a heart transplant, what does this mean for me? So the system is designed to better prioritize. So if you have heart failure, you should be seen by an advanced heart failure center who can assess you and kind of determine where you are in the trajectory and your imminent need for needing advanced therapies. If you are, then that center will typically, and our center will evaluate you for these therapies, and based on your need for transplant, we would prioritize you in the UNOS statuses as I've discussed today. Thank you for your attention.